Hi, it's Dr. Silva, and today I'm going to talk to you about Vyvanse, lisdexamfetamine. This is a dopamine norepinephrine reuptake inhibitor and releaser. So it blocks the reuptake of dopamine and norepinephrine, which increases the concentration of those neurotransmitters at the synapse, as well as causing the release, i.e. it's an amphetamine, spelled phonetically for some reason. But it differs from methylphenidate, which are the Ritalin, Concerta, Focalin preparations that are also used, also stimulants, because those are norepinephrine and dopamine reuptake inhibitors only. They don't cause the release of those chemicals. The amphetamines, medications like Adderall and Vyvanse, they go a step further. And so they're more intense, they are more stimulating, and in some respects more effective, but also the side effects tend to be more intense. The difference with Vyvanse is that it's a prodrug. It doesn't convert into its active form until it reaches the intestines and becomes dexamphetamine, dextroamphetamine, dexedrine, and L-lysine, an essential amino acid. Because of it being a prodrug, there is both a delayed onset of action as well as a prolonged action, 10 to 12 hours. So it has to be taken in the morning. But unlike Adderall XR, for example, which is also extended release, Vyvanse takes it about an hour before you can actually begin to feel the effects of it. So it has to be planned accordingly. Take it first thing in the morning. I usually recommend to patients to take it as soon as they wake up, and about 1 to 2 hours before they hit work or school or wherever they need for the medication to be effective. There is some speculation that because of this mechanism of action that there might be less abuse potential. And certainly in general, I've found that when you compare Adderall immediate release to Adderall extended release, for example, that there is probably a little bit less tendency to abuse the extended release than the immediate release, just because of the pharmacokinetics of the medication. The advantages of using an extended release preparation, other than single daily dosing, take it in the morning, forget about it, is that you have a smoother peak and you also have a smoother letdown, so that when the medication starts to wear off, you don't crash. Some people on the immediate release really crash with it. They feel an abrupt loss of efficacy and maybe even rebound symptoms of inattention and lethargy and somnolence. And people that tend to abuse these medications in general prefer the immediate release because it's easier to take extra doses, it hits a person faster, the euphoria is more intense. But Vyvanse gets good reviews, even among those patients that are somewhat seduced by the euphoria. And not necessarily patients that are abusing their medication, but patients that they are sort of distracted by the side effect of euphoria, because the euphoria is a side effect. It may be a welcome side effect, but it's not what we're going for. It's just an unavoidable consequence of using a stimulant and of increasing dopamine. But even in those patients that identify the medication, quote unquote, working with feeling that elevated mood, even in those patients, I get good reviews when I switch them over to Vyvanse. And a lot of those patients really prefer immediate release. When I try to give them extended release, they don't like it as well. They come back and say that it doesn't work as well. For whatever reason, even innocently enough, they tend to prefer the immediate release. But when I switch to Vyvanse, even in those patients, they like it. They give it the thumbs up, and a lot of times they want to continue it. So there's something about Vyvanse that, even though it is a prodrug with a delayed onset of action and an extended duration of action, it gets good reviews. And I've actually never taken Vyvanse. I've taken a lot of medications, a lot of substances. I happen to be in remission from substance abuse, but I have had Adderall, both immediate release and extended release, and I know what those medications feel like and what the difference is between those two preparations. I've taken methylphenidate and Provigil and all that, but I've never taken Vyvanse. So unfortunately, I can't give you a first-person account as to what Vyvanse feels like or why patients like it. All I can tell you is that I have never had a patient tell me that they didn't like it and that they wanted to switch back. So something about Vyvanse. It's very popular. It's a popular prodrug. You can take it with or without food. You can even open up the capsules and dump the beads into a glass of water. It's a prodrug. You still get the same pharmacokinetics even if you open up the capsules. You just have to be sure to drink the entire glass of water. It's FDA approved for the treatment of ADHD in children ages 6 and older. And it also is approved for binge eating disorder. It's the only drug, the first and only drug that is FDA approved for binge eating disorder, and it works. It does very well in those patients to stop the food obsessions and to curb binging and to give those patients a sense of control over their eating behavior. I think it's very effective. And all stimulants, particularly amphetamines, are going to cause a certain degree of anorexia at the beginning. But with medications that, like Adderall, that are amphetamines, both immediate release and extended release, after a few weeks or months, it's different for every patient, you do develop tolerance, a certain degree of tolerance to the anorexia that's induced. And it could be sort of a relative tolerance, or it could be an absolute tolerance where it's really no longer suppressing your appetite. And so I always tell patients who are also trying to lose weight that if they want to exploit that particular side effect or perhaps welcome effect of the stimulant, that they need to concentrate their efforts, their weight loss efforts, when they begin to take medications that suppress the appetite. Medications like Adderall, or for that matter, Concerta or Ritalin. But you do develop tolerance to that, and after a while, it's really not suppressing your appetite to a significant degree, and you can overeat and you can gain the weight back that you might have lost. But with Vyvanse, patients with binge eating disorder obsess about food and they actually feel out of control when they eat. They do not tend to develop tolerance to that. So there does seem to be a long-term benefit to taking, in particular, lisdexamfetamine. That's what's been studied and FDA approved. And there's research that shows that it's good for up to 26 weeks. In my patients that I've prescribed it to for years, I've not seen any significant tolerance to the, not necessarily the anorexigenic effect of the medication, but simply the effect that gives patients control over their eating. It does tend to be a sustained effect. And I have prescribed quite a bit of Vyvanse. Side effects. Well, the usual suspects: nausea, headaches, and diarrhea. I always say almost any medication can cause nausea and headaches. Those are very nonspecific, general side effects. Diarrhea is also very, very common. But because Vyvanse is a stimulant, it can also cause constipation. Stimulants tend to maybe provoke bowel movements. We know that to be true of caffeine, and a lot of times people, when they smoke nicotine, and also with stimulants, including amphetamines. But over the long term, they do slow down gastric motility because amphetamines increase norepinephrine, and norepinephrine is a sympathetic nervous system neurotransmitter. It's the fight or flight system, and so digestion is not a priority, and you salivate less, you get the dry mouth, there are less gastric secretions, and you get a slowing of gastric motility, which in some patients can bring on constipation. You also get all of the other side effects that stimulants induce. I've mentioned dry mouth already. That's very, very common. It can also be exacerbated by caffeine. So if you're combining stimulants, you can get even more dry mouth. Insomnia, of course, because it's a stimulant, but also this is a long-acting preparation, so you've got to take it in the morning. I would not take Vyvanse in the afternoon at all, not past noon at all. You can always be overstimulated if the dose is too high, or you intentionally take more than you should, and that leads to nervousness, tremor, which again can be compounded if you mix it with other stimulants, including caffeine, mania in those patients that are prone to mania, patients with underlying bipolar disorder, or even anybody who takes intentional overdoses or who abuses it, takes it recreationally. So you would see the signs of an elevated mood, of mania. You would see psychomotor agitation, you would see pressured speech, logorrhea, just talking a lot more in general, an excitement, an impulsivity, increased libido, which is a direct effect, but also an aspect of mania, hypersexuality. In the extreme, you can see psychosis, including hallucinations, paranoia, grandiosity, delusions. But those aren't really side effects, those are really toxic effects, effects that you would get in overdose. It can cause irritability as a side effect, and again, you can get a double whammy situation if you combine it with other medications that also cause irritability. Women during the late luteal phase of their menstrual cycle can also be particularly vulnerable to stimulant-induced irritability, so that's something to watch out for. The anorexia that I've already talked about can certainly lead to weight loss. That might be a welcome effect, or it might be a side effect if it's not something that we want. It does tend to plateau even in patients that take these medications in the long term. Peripheral vasculopathy, what is that? Well, epinephrine, norepinephrine, and epinephrine, they cause vasoconstriction in the periphery. So they cause the arteries in particular and the arterioles to vasoconstrict, and this raises blood pressure. It also leads to, in some instances, certainly not in all cases, but it could lead to Raynaud's phenomenon. Raynaud's phenomenon is a condition that involves the constriction of the smaller arteries, the arterioles, supplying blood to the skin, to constrict excessively in response to cold or stress. Stress can also bring it on. The vasoconstriction is excessive. This is controversial, but there is evidence to show that it can retard growth in children. Now, this is a retardation. It's a slowing of the normal growth curves in children. It's not a stunting per se, because studies have shown that what ultimately determines their final height is parental height, i.e. genetics. And so kids do tend to make up for the fact that they're a little bit behind the growth curve. Still, you want to monitor weight and height, especially in children, and summer breaks when they're not in school is the standard of care. And it's very small children that are very hyperactive. Taking summer breaks may not be feasible, but you still want to take drug holidays whenever you can, particularly as they get older, and research does show that they end up being as tall as they're supposed to be, even though they took medication. Sexual dysfunction. In the short term, stimulants can be beneficial for sexual functioning. It increases the libido for sure, and it can actually be a very, very effective antidote. I think the most effective antidote to the problems caused by, for example, serotonergic medications, the SSRIs, for example, like Prozac and Paxil. You actually get an improved libido because of the dopamine, and it's actually the most effective pharmacologic antidote for drug-induced anhedonia. And so if you've got somebody who's lost their sex drive because they're on Paxil, adding a medication that's dopaminergic, and particularly one that not only blocks the reuptake of dopamine but causes the release of dopamine, as Vyvanse does and as amphetamines do. But even medications that simply block the reuptake of dopamine, Wellbutrin can be effective at increasing the libido. However, as far as erectile functioning, it's the opposite. The parasympathetic nervous system is what's responsible for the male erection. Is that redundant? I don't know if that's redundant, but the erection is impeded if you have sympathomimetic neurotransmitters that are elevated, and that would be norepinephrine because of the sympathetic nervous system. So the fight or flight is not conducive. Stimulants can also exacerbate tics, That's everything from biting your nails to trichotillomania, pulling at your hair, and other things that people do, picking at their skin and clucking their tongue and blinking and shoulder rolling, and there's all kinds of tics. The stimulants are relatively contraindicated in tic disorders and absolutely contraindicated in Tourette's, which is a very serious tic disorder. Life-threatening, dangerous side effects include psychotic episodes, but again, this would be an overdose or if it's medications being abused, or in patients with schizophrenia. These medications are relatively contraindicated in schizophrenia. They do lower the seizure threshold, and so again, if the dose is too high, or if the patient overdoses, or if the patient has epilepsy, or is taking other medications and combining them, other medications that also lower the seizure threshold, you could get seizures that could be very serious. You could fall and hurt yourself. It could be life-threatening, really. Status epilepticus is life-threatening. That would be rare due to a medication. Palpitations, because these medications increase heart rate, so you can get tachycardia, which is elevated heart rate, as well as hypertension. You do have to monitor hypertension in these patients. You have to monitor blood pressure. And a person who has severe, uncontrolled hypertension cannot take stimulants. So a person that just has high blood pressure would be a relative contraindication, not a medication that you couldn't use. You'd have to do the risk-benefit analysis. There are very serious cardiovascular adverse effects. Sudden death has been reported in patients with pre-existing cardiac structural abnormalities. In adults, you do monitor the blood pressure and the pulse, and a cardiac assessment is always necessary prior to prescribing this medication. Stimulants have lots of contraindications. Some of these are absolute contraindications, some are relative contraindications. It depends upon the severity. You always do a risk-benefit analysis. You always discuss in detail your particular case, your particular history and symptoms with your physician. Patients with high anxiety, poorly controlled anxiety and agitation, tic disorders, especially Tourette's, atherosclerosis, including coronary artery disease. Other cardiovascular disease also needs to be reviewed. Cardiomyopathy, which is disease of the actual cardiac muscle, the heart muscle itself. Arrhythmias are also relative contraindications, severe hypertension, and patients who already have Raynaud's or other vasculopathies. You also want to be very careful in patients with glaucoma, and specifically narrow angle glaucoma. It could exacerbate that, and it could lead to blindness in the worst case scenario. Patients with hyperthyroidism who already have tachycardia and sweating, you just compound a lot of symptoms of hyperthyroidism. In patients with stimulant use disorder, there's an absolute contraindication. You don't give it to patients with a history of cocaine disorder, for example. Other use disorders, there is a relative contraindication. So you can use stimulants safely in some alcoholic individuals, but other alcoholics or Xanax addicts that also like to smoke marijuana and that abuse psychedelics, etc., polysubstance dependency, a lot of those individuals are at much higher risk of also abusing stimulants, particularly amphetamine. Patients that are experiencing psychosis, certainly absolute contraindication. Patients that are prone to psychosis, such as patients with schizophrenia and bipolar disorder, and then patients that are just emotionally unstable. You would want to be very cautious about using amphetamines in patients who are moody, who are impulsive, and who have poor control of their behavior. Some of the advantages of Vyvanse: it is once daily dosing. There's a wide dosing range. It goes from 10 to 70. There may be less abuse potential because of the pharmacokinetics of this particular medication, and it is popular. Disadvantages: it is expensive. There's no generic as of yet. As of now, there's no generic preparation, and a lot of times most of the time insurance companies will require prior authorization before they will be willing to pay for it, which also means that you probably will have had to have tried other stimulants, not necessarily long-acting ones, but just other cheaper stimulants before the insurance company will say, yes, you can try Vyvanse. So you have to fail other drugs a lot of times to get it approved. It is the only medication that is FDA approved for binge eating disorder, however, so if you've got that, you will be able to get it. You'll be able to force the greedy insurance companies to pay for the drugs that you are paying for through your premiums. Don't get me started on insurance companies. That is Vyvanse in a nutshell. Again, very popular. I've prescribed it a lot. I've never had a bad review. I've never had a patient say to me, I want to go back to Adderall XR, or even Adderall IR, immediate release for that matter. So I've been impressed with it, and it's first line for patients with binge eating disorder. Thanks for listening.